Sorry. Thank you so much for that introduction. I'm honestly honored to be here. This conference every year seems to just get better and better, and I'm really looking forward to all the other talks through the afternoon. I know I'm going to learn a lot. But I was asked to sort of introduce ARDS in general and sort of the general background of ECMO. So the definition of ARDS, and does this point?
Yes.
Awesome. Great, thank you. So the definition of ARDS has been evolving over time, but it's essentially an acute onset of respiratory failure characterized by bilateral lung infiltrates and severe hypoxemia. The definition that I've been living with for most of my clinical career is the Berlin definition, where you have the criteria that it's been less than a week and you have bilateral consolidations and that your P to F ratio is less than 300 on at least 5 a peep. And that definition has pretty much stuck, but more recently there have been some additions to allow for the diagnosis to be made in patients who are on high flow and for the use of ultrasound in more research poor environments. And what does it look like? So this is pretty much an I can't laser point without advancing the slide, it seems. So this is what the X-ray looks like. Bilateral infiltrates. There's usually a basilar predominance and a posterior dependent predominance. And then when you look at the actual path, what you see is the development of non-cardiogenic pulmonary edema, sort of represented by this pinkish fluid here. There's intense inflammation. And then over the first 3 days or so, the development of these hyaline membranes. And this clinical picture is known as diffuse alveolar damage, the pathologic picture rather, and it's not unique to ARDS. That's sort of a common final end stage of a lot of pulmonary injuries, but that is the most common pattern that you see in ARDS. But I put this slide up just to say, I think anytime we're diagnosing someone with ARDS, we should pause for a second and just ask ourselves, does this patient really have ARDS? Because autopsy studies have shown us that only about 2/3 of the patients who are diagnosed in life with ARDS actually have diffuse alveolar damage when you look at their autopsy. And this maybe isn't so bad because another significant proportion have pneumonia, and some authors have argued that pneumonia is also a compatible pathologic finding with ARDS. But the thing that kind of gets me is that approximately 15% of these patients actually have no discernible lung injury, which is sort of shocking, but I think represents that these patients probably in life had atelectasis, because when they do the slides, they actually inflate the lung and then they make the slides. So obviously that would resolve at the time of pathological examination. And the other thing is, buried in this other group is a lot of things that would definitely change management, right? Something like MDA5 RPILD, for example. Something where the management would have been totally different than what you were doing otherwise. So I always make sure that I pause sort of 3 times and think, does my patient really have ARDS? Because also included in this group are just patients who had cardiogenic pulmonary edema. And the last thing you want to be doing is finding out that that was the case at autopsy. So I find it helpful to think about, what do I think is the cause of my patient's ARDS? And these causes, I don't know why this is like spontaneously advancing, but these causes are divided into direct lung injury or primary ARDS, things like pneumonia, inhalational exposures, aspiration. Ventilator-induced lung injury has that same pattern. And then indirect lung injury or secondary ARDS, which are things like neurologic processes like seizure, pancreatitis, trauma, fat embolism. All of those things can also cause ARDS. So in order to avoid misdiagnosis, it's often helpful to think about, well, what caused this patient's ARDS? And then once we've decided our patient has ARDS, how are we going to manage it? So I put this slide up just to summarize the recent positions from the American Thoracic Society and the European Society for Intensive Care Medicine. And interestingly, in 2017, the last time they issued guidelines, they issued joint guidelines. But this time around, they decided to part ways and issue separate guidelines, which led to a couple sort of interesting discrepancies. So one thing is, both groups strongly endorse the use of low tidal volume ventilation, lung protective ventilation. They both strongly endorse the use of prone positioning. We know that that's associated with a mortality benefit in moderate to severe ARDS. But I highlighted the ones where either there were new recommendations that they hadn't made previously or where they're disagreement. So when it comes to higher PEEP strategies, there is some disagreement. The American Thoracic Society issued a conditional recommendation for the use of higher PEEP strategy in moderate to severe ARDS, whereas the Europeans say, there's really insufficient evidence to recommend for or against a particular PEEP strategy. Both groups issued for the first time strong recommendations against recruitment maneuvers, especially prolonged recruitment maneuvers, but the Europeans also issued a weak recommendation against the use of even short recruitment maneuvers. And for the first time, the American Thoracic Society issued a recommendation for the use of corticosteroids. And then when we get to the neuromuscular blocking agents, I think this is a very interesting story. So the ATS recommends like a weak recommendation for the use of neuromuscular blocking agents in early severe ARDS, whereas the Europeans have a strong recommendation against their use. So this is sort of an area of seemingly major difference. So I thought I would go into the weeds just for a second to sort of flush out how did we get to these differing recommendations so that we can make educated decisions when we treat our patients. And with regard to the PEEP situation, it's fair to say there are no direct randomized controlled trials that have shown a survival benefit to higher PEEP strategies in ARDS. So the Europeans have concluded, there's insufficient evidence because there are no randomized controlled trials that show benefit. But the American Thoracic Society cited this Bayesian network meta-analysis when they made their recommendation. And this meta-analysis included 18 randomized controlled trials, including almost 5,000 patients. And the main top-line result was that they found that the posterior probability of benefit for a higher PEEP strategy was 99%. Over here in the, let me see if I can try this one more time. Over here, 99% the posterior probability of a benefit of a higher PEEP strategy. So this was the evidence that the ATS used, and that's how we came to the differing recommendation. The neuromuscular blocking agent story, I think, is even more interesting, especially for a group of us who love ventilators. So this story begins in 2010, the publication of the Accurasis trial. And this study was a small randomized controlled trial of moderate to severe ARDS, and they randomized patients to deep sedation, so RASS of -4, or deep sedation plus paralytics. And what they found was, in that study, there was a significant improvement in mortality in the cisatracurium group. And so this prompted a lot of providers to routinely use paralytics in the management of ARDS, especially early. But subsequent to that, two major changes happened, I think. One is that the clinical practice kind of shifted, and deep sedation was found to be harmful in a lot of cases. And so we started no longer utilizing deep sedation routinely. And the other thing is that in 2013, only a couple years after this paper was published, the concept or the entity of reverse triggering was discovered. And reverse triggering is a form of ventilator desynchrony that is actually brought out by deep sedation. And so a lot of authors postulated that perhaps the benefit of the paralytic was that you were actually just stopping the reverse triggering that was being triggered by the deep sedation. So they redid the study. And in 2019, the ROSE trial was published. This was a larger randomized controlled trial, had over 1,000 patients, and randomized patients to light sedation this time, RASS 0 to -1, or deep sedation plus cisatracurium again. And what they found in this case was that there was no longer a survival benefit to paralytics. They found no evidence of a survival benefit. And so we're left sort of saying, okay, well, what's different about these studies, right? And so possible explanations have been, the ROSE trial randomized patients earlier. So some people say, well, some of those patients may have rapidly resolving ARDS and have lowered the overall mortality rate in the group. They did use higher PEEP in the ROSE trial, but there was less proning. So there are some differences, but it's hard to tease out how that would go which way. And then interestingly is this idea of reverse triggering. So I thought just for this group, I would take 2 seconds and talk about that. So reverse triggering is a type of ventilator desynchrony that is actually triggered by the ventilator. So what you see here in the top is essentially patient triggering breaths in a pressure targeted mode. You can see a descending ramp on the flow, so it's a pressure targeted mode. And this is a measurement of diaphragmatic activity. So you see the diaphragmatic activity go up, a little pressure deflection negative shows you that it's a patient triggered breath, you get the breath. But under here in B, you see a patient who's also on pressure control, but has reverse triggering with a 1-to-1 ratio. So you can see the first breath is actually a controlled breath. There's no diaphragmatic activity here that triggers this breath. But then immediately following the administration of this controlled breath, you get diaphragmatic activity and a little bump in your flow here. And then in this final one, it's sufficient enough to trigger another breath. And so there are a lot of different mechanisms, and there are honestly probably more than one mechanism that can contribute to reverse triggering. But the most commonly cited mechanism is this thing called respiratory entrainment. And it's sort of vague, but if you bear with me, basically it says that the ventilator delivering this breath causes a stimulus to the chest wall muscles and the diaphragm muscle and the lung stretch receptors, and that somehow that impacts this central pattern generator region of the brain to put an output that causes a pattern respiration rate that happens to exactly match the ventilator rate of the input. And so you can see reverse triggering in a 1-to-1, you can see it in a 2-to-1 or a 3-to-1 pattern, and sometimes it's even random, but it usually has some sort of relationship to the ventilator rate. And why do we care? Well, we care because this has the potential to induce ventilator-induced lung injury. So it causes increases in your transpulmonary pressures, your distending pressures. We can see right here how it can lead to breath stacking and lead to larger tidal volumes. And then it's also a potential source of pendulift, where you have one area of the lung emptying into the other, and that's also a mechanism of ventilator-induced lung injury. And so how do we treat it? So the authors recommend that you can increase the I time, you can decrease the respiratory rate, but a lot of times in severe ARDS, you're kind of already up against it, right? I mean, you can't really, your respiratory rate is set as high as it's set because the patient is super hypercapnic. If you start decreasing the respiratory rate so you can lengthen your I time, then you might get, you may be up against the 7.2 or the 7.15 pH threshold. And alternatively, if you just start lengthening the I time without lowering the respiratory rate, you can induce air trapping and increase intrathoracic pressure, start dropping your blood pressure and get into that whole cycle. So, but one thing you can routinely try, and I have had actually some success with this at the bedside, is that you can see here, the thing is that deep sedation actually brings out reverse triggering. The deeper your sedation level, the more likely you are to have reverse triggering. And there are studies with propofol where they actually test this, where they actually put an esophageal balloon in and titrate the propofol to different levels of sedation and show that the incidence of reverse triggering is going up. In at least one study, opiates are protective. So for every 10 micrograms per hour the fentanyl drip was increased, the rate of reverse triggering, or the incidence of reverse triggering, went down by 7%. So essentially, if your fentanyl drip is 100 micrograms per hour higher, you're 70% less likely to get reverse triggering. So, and for me, this kind of jives with my view of the universe. I was taught, and I try to teach others, opiates are really for air hunger and for ventilator synchrony, and sedatives are for level of agitation or arousal or climbing out of bed. And I think if you're using the right drug for the right problem, you can often avoid this kind of situation. But I thought I would, and then, if you can't, then you might have to go back to deep sedation, add paralysis, because you don't want to let people just double trigger, right? Because you'll get ventilator-induced lung injury. So out of the weeds, back to where we left off, and back to the crux of this talk, which is, for the first time, both societies have issued a recommendation for the use of ECMO in severe ARDS. So from the ATS, it was a conditional recommendation, and from the Europeans, it was actually a strong recommendation. So this is an ECMO circuit. Essentially, this is a picture from the Red Book. You're drawing blood out of a vein and running it through a pump, and that pump is pumping the blood through a membrane lung, where oxygen is being added and carbon dioxide is being removed. And then the oxygenated blood is being returned to the body, either through a vein, if you're just trying to perform the job of the lungs, or you can also return this blood into an artery if you're trying to also provide hemodynamic support, if your patient needs help with their heart and their lungs. So what is the evidence for using ECMO in ARDS? There are basically these two trials that form the sum total of the evidentiary basis for the use of ECMO in ARDS. It was the EOLIA trial, which randomized patients with very severe ARDS, so you had to have a P to F ratio less than 50 for 3 hours, or less than 80 for 6 hours, or severe hypercapnia resulting in acidosis. And what they found was, interestingly, there was pretty good separation of these curves. There was a I would say, pretty strong numeric trend towards improved survival in the ECMO group. But the p-value was 0.07, and the study was actually stopped early for futility. It crossed, I guess, one of the predetermined levels of the triangle for futility. And so one thing you should know about this trial is that it was stopped early. And the other thing is that there was significant crossover. So 28% of the patients who were randomized to no ECMO ended up getting ECMO. And if you read the paper, these were very sick patients. I mean, all of them had rising lactates, increasing pressor requirements. A fair number of them, I think 9 of them actually had a cardiac arrest before going on ECMO. And all of them had severe hypoxic respiratory failure. The median oxygen saturations were in the low 70s before these patients went on ECMO. And the mortality of those patients was like 50%, which I think is pretty good actually for a group of patients that are so sick. So even though the top line result of this trial was that it was a negative trial because the p-value was greater than 0.05, I think most of the world has interpreted this as actually pretty strong evidence for the use of ECMO in ARDS. The other trial is the Caesar trial, and it is also not perfect. So this was a trial performed in the UK, published in 2009. They randomized patients with mainly H1N1 to ECMO referral to an ECMO center versus remaining at the hospital where they did not have ECMO. And there was a significant survival benefit to being referred to an ECMO center. But interestingly, not all of these patients got ECMO. So the 76% of the patients who were referred to the ECMO center received ECMO. So, one of the limitations of this trial is it actually showed that there's a statistically significant benefit in mortality to being referred to an ECMO center. It wasn't directly evidence that there's a benefit of ECMO. But I think, when the ATS and the European Society did their most recent guidelines, they performed meta-analyses of this data. And they both concluded in relatively similar numbers that there was a high probability that there's a survival benefit to ECMO in severe ARDS. And that's how we got to that recommendation. So ECMO is increasing, right? There are over 500 centers, ELSO centers in the world doing ECMO, over 18,000 ECMO runs a year. And when should we consider it? So now we know it's recommended, we know the evidence, when should we consider it? And we talked about the entry criteria. So this is for patients with very severe ARDS. We've got our PDAF criteria here, which are based on the Eolia trial that we went over. One thing we should know is that probably the earlier the better. So one thing that we know is from the ELSO data is that if you've been on mechanical ventilation for more than 7 days, your outcomes are worse. They may still be better than they would be if you didn't get ECMO at all, but versus people who went on ECMO within 7 days of mechanical ventilation, their survival is lower. So we really like to put people on ECMO within 77 days of mechanical ventilation. Some people even say 48 hours. The other thing is, this is assuming that the ventilator has been optimized, that prone positioning, if able, has been tried, and probably a trial of paralytics, depending on whose guidelines you want to believe. And then the other thing I wanted to comment briefly on is just inhaled pulmonary vasodilators. I think every single time I mention that I think we should prone a patient or that perhaps this patient needs ECMO, it's always like 100% of the time the topic of, should we start Velitri? Or do you want to try Velitri first comes up? And I think that's fine. And I think inhaled pulmonary vasodilators are a reasonable bridge to proning or a bridge to ECMO. But the thing we should keep in mind is that there's no mortality benefit to pulmonary vasodilators. So although they can transiently help with oxygenation, the trials have shown no evidence of a mortality benefit to this therapy. So this is not something that should supplant other therapies for which there has been ascribed a mortality benefit, like proning or ECMO. So, and then what are the patient selection factors that we consider? And I put this slide up mainly just because I think it's I don't know, funny is not the right word, but so, according to the most recent ELSO guidelines, the only absolute contraindication to VV ECMO is that you have irreversible lung injury and you're not a transplant candidate. Everything else is a relative contraindication, including irreversible and incapacitating central nervous system injury. So, I think this slide just highlights the importance of having local guidance, because I think with this, where even patients who have a severe neurologic injury that's irreversible and incapacitating could still potentially be a candidate for ECMO, it really highlights the fact that we need to have local guidance and people sort of establishing whatever your hospital's factors are going to be. But you need to be on anticoagulation for ECMO, so systemic bleeding, central nervous system hemorrhage, contraindications to anticoagulation. Age is an important predictor of mortality. So the inflection point, unfortunately, is actually around 40. So if you're over 40, your mortality starts to go up, and then every decade of life after that, your mortality goes up on ECMO, unfortunately. And then we talked about the ventilator thing. And then once you're going to put your patient on, how are you going to do it, right? So I made this slide with ChatGPT, so if you find anatomic discrepancies, I apologize. But basically, the two most commonly utilized strategies are these VV strategies, so especially for ARDS. So the VV basically means you're drawing the blood out of a vein, and then you're returning it back into a vein. And there are two sort of most common ways to do that. You can either draw it out of one femoral vein and put it back in the other femoral vein, or you can draw it out of a femoral vein and return it via the IJ. And so this is sort of maybe better in an emergency because you can just prep one site and cannulate both sides simultaneously. And this may be favored if you have the time to do it because there's a little bit less recirculation. If you have, we'll talk about recirculation again in a minute, but if you imagine if you have this drainage cannula that's sucking 5 liters of blood into it every minute, and then a return cannula that's jetting 5 liters of blood out, if they're really close together, you can just recirculate that blood back into the drainage cannula. And so that oxygenated blood is not being delivered to the patient. So if you have the cannulas on opposite sides of the atrium, you tend to get a little bit less recirculation. So some people prefer this configuration. And then, you can also do what's called VV-V. So you can add a second drainage cannula, and now you're draining from both femorals and returning via the IJ in this example. And this is particularly helpful if you have what's called drainage insufficiency. So if you're trying to flow 5 liters of blood, but you're generating such negative pressures that it's just sucking the inferior vena cava flat, then you can try to get away with less flow. You can give a little volume to see if that helps, but you don't want to give too much volume because you can get into a vicious cycle in that regard. And so sometimes what you have to do is actually put in a second drainage cannula so that you can get adequate flows. Alternatively, if your patient develops RV failure or needs both respiratory and cardiac support, you can do what's called V-A or VA. I don't know why I put it AV. Usually I say VA. But basically you're drawing from the vein and then you're returning to an artery and a vein. So you're drawing here from the femoral vein and then you're splitting your return, and some of it is going to the vein and some of it is going to the artery. And you can put a clamp on the venous circuit to adjust how much flow goes to which side. The other thing you can try is that recently, especially, there's been a lot more publication of cases using Protect Duo cannulation. This cannula goes in the IJ, goes down into the right atrium, through the tricuspid valve, and out into the pulmonary artery. And it has two ports, one that can draw from the atrium, and then one that can return the blood into the pulmonary artery. And so you get better capture and no recirculation because your ports are far apart. And this also provides some RVAD support if you have RV failure. And the Protect Duo is actually pretty versatile. I've actually never used this configuration myself, but this was published in the literature. In this case, they were draining with 2 drainage cannulas via the femoral veins and running through the pump and the membrane lung, and then returning through both ports of the Protect Duo. So that's obviously off-label. I'm not recommending that, but I put it up here just so you can get an idea of the creative ways in which you can construct these circuits. So, and then Dr. Mason-Otis is going to give a talk on ventilator management once you're on ECMO, but I just wanted to say, simply put, once you're on ECMO, the goal is to rest the lung, right? And so we have to sort of resist all of our knee-jerk reactions. Everything we've been trained to do is all of a sudden not the thing to do. So, we really want to address hypoxemia or hypercapnia with the ECMO circuit whenever we can. And so if the patient is having oxygenation problems, you can adjust the fraction of delivered O2. It's not inspired, it's delivered. And then, or you can adjust the flow, which you would adjust the RPMs on the ECMO circuit. And if they're having issues with CO2 clearance, instead of increasing your tidal volume or your rate, you would just increase your sweep. And one thing I will say is, before you go on the ventilator, we've all lived in this world of permissive hypercapnia. right? One of the side effects of low tidal volume ventilation is that your patients often get hypercapnic, and we have learned to sort of ignore that and to just say, as long as your pH is above 7.25 or 7.2 or 7.15, we're okay with it, unless you have a contraindication to permissive hypercapnia. But when you first go on ECMO, the CO2 clearance of the ECMO circuit is amazing. And you have to be a little careful to avoid overly rapid reduction in your PCO2, because this can cause cerebral edema. So this is where communication really comes in handy. And communication between the respiratory therapist and the ECMO team and the ordering providers, and just making sure that everybody's on the same page about what are we going to do with the vent once we're on, what are we going to start or sweep at, what do we think our goals are for the first 4 hours. And in general, a good rule of thumb is to avoid reducing the PaCO2 more than 50% in the first 4 hours. So the last thing I wanted to talk about is take a few minutes to talk about the circle of life. So there are many circles of life. This was taught to me as the circle of life, but now I've learned there are other circles of life as I get older, and I've realized this is just a circle of life. So this is the circle of life that describes how blood is oxygenated in the lungs and then is carried to the capillary bed where oxygen is extracted so that the tissues can utilize the oxygen in performing metabolism. And then the blood returns to the lungs desaturated, where it gets resaturated, and around you go. And normally your arterial saturation is around 100%, and then your mixed venous or central venous saturation is, say, around 70%. But we become so fixated, I think, sometimes in the ICU at the bedside on the PaO2. And I think that causes us sometimes to miss the forest for the trees, because the meaningful variable in oxygen in blood is not the PaO2. It is the oxygen content, which is literally how many milliliters of oxygen are in this liter of blood. And the way you figure that out is with this equation, which if you look at it is 1.34 times your hemoglobin, which is, 10, times your saturation, which say if it's 100% would be 1, because it's as a fraction, and then plus 0.003 times your PaO2. So whatever your PaO2 is, you're multiplying it by 0.003 to get this number. So when you do this, and I encourage you to do this, if you do it, what you'll find is that somewhere between 50 to 100 times more oxygen is circulating bound to hemoglobin than just dissolved in the blood. And put another way, the dissolved oxygen only accounts for about 1% of the oxygen that's actually being provided. And so, but that only tells you part of the picture, because the amount of oxygen being delivered is the amount of oxygen in every liter of blood, and then how many liters of blood are you delivering to the tissues every minute? And that's your cardiac output. So if you multiply your oxygen content times your cardiac output, you get the delivery of oxygen. And in a normal circumstance, it's about 1 liter a minute. 1 liter of dissolved oxygen in every minute circulating through your capillary bed. And the oxygen consumption is usually around 200 milliliters every minute, or 120 milliliters per meter squared or body surface area. But in general, the DO2 ratio, the ratio of delivery of oxygen to oxygen usage, is about 5 to 1. We'll see why that's so important here in a second. But the other thing to point out is that because of this equation, you can see that if too much oxygen is being extracted in the tissues, and by that I mean as a percentage of the oxygen that is being delivered, even if the tissues are still extracting the same amount of oxygen, if there's less oxygen coming through every minute, then the blood will be more desaturated coming back to the heart. There'll be a lower central venous sat or mixed venous sat. And that can be low either because the cardiac output is low, so there's just less oxygen per minute going through, or because the lungs are failing, or the patient is severely anemic, so there's just less oxygen in every liter of blood. So on ECMO, this becomes even more complicated. So on VV ECMO, you have to account for this mixing of streams, right? You have most of the ways that we usually gauge cardiac output are unknown in VV ECMO for reasons that I won't go into right now. But you have to account for this mixing of streams. So you have the native venous flow coming back to the heart that has very low oxygen because the lungs are failing. And then you have this really oxygenated flow coming from the ECMO circuit. And these are mixing here in the right atrium. And so the overall oxygen content of the blood that's circulating is the mix of those two streams. And so the equations are here. They're frankly a little mathy, so I'm not going to go into them in this setting with a 30-minute overview, but they're in this paper by Dr. Bartlett and in the Red Book, and there are great examples there you can work through. But basically, when you do this math, what you find out, and this is the most important take-home, I think, is that the oxygen delivery is often fine with patients with hypoxemia. So even if their SATs are in the low to mid 80s and their PaO2 is in the 40s or 50s, the amount of oxygen being delivered is okay. And so we really want to avoid overreacting to low oxygen levels in VV ECMO. Literally every single patient on VV ECMO will have hypoxemia. And so the DO2-VO2 story just includes this other bit, and that is that as the normal ratio is 5:1, and as the delivery of oxygen begins to drop and the oxygen utilization stays constant, the tissues are happily unaware that anything is happening, they're continuing their aerobic metabolism, they're doing all the things they like to do, and then you cross this magic threshold around a ratio of 2:1, where all of a sudden, due to limited availability of oxygen utilization starts to drop because anaerobic metabolism takes over. And this is where you get production of lactate, organ failures, tissue hypoxia, to be differentiated from blood hypoxemia. And this is what you want to avoid. So usually when you're on the ECMO circuit, you want to target a DO2-VO2 ratio of about 3:1. And often we will just use the pre-oxy SAT to try to approximate where we are with the DO2-VO2, unless there's a problem and then we feel like we have to go through the whole equation. But normally, this assumes that there's no recirculation. Because we just said if your cannulas are too close together, you're going to get this recirculation problem. And what's going to happen then is that your mixed venous saturation is going to be artificially elevated because the blood coming back to the ECMO circuit is going to be fully oxygenated, but the body's not going to be receiving that oxygen. And so the last thing I wanted to talk on is what do you do in that circumstance if you have low DO2, right? So instead of manipulating the ventilator, what can you do instead? So one thing you can do is you can increase ECMO flow. You may even need to add another drainage cannula to do that. You can transfuse red blood cells because you can see from this graph that blood with a hemoglobin of 15 has twice the oxygen carrying capacity as blood with a hemoglobin of 7, but the usual target is around 9, according to the most recent guidelines. Or you can decrease VO2, right? You can sedate patients, you can paralyze them. You should definitely avoid fever, and you should possibly even consider cooling these patients if you're really in a pinch. And with that, I will stop. I'm sorry.